Have you ever wondered what really goes on inside a psychiatric assessment? Movies often paint this picture of a super intense interrogation, right? But the reality is, it's so much more human than that. It's really a partnership, a carefully structured conversation designed to understand a person's entire story. So, let's pull back the curtain and see exactly how clinicians piece together this incredibly detailed puzzle of the human mind.
So, what makes a psychiatric interview so different from, say, your annual checkup? Well, while a regular doctor might focus on your physical symptoms, a psychiatric interview has to dig way deeper. It's built to account for the fact that disturbances in our thoughts or emotions can totally change how we communicate. It's not just about the words someone says. It's about listening to family, understanding a person's whole life story, and just really sharp observation of their behavior. The end goal isn't just a label or a diagnosis. It's about building a complete, rich picture of a person.
All right, so here's a roadmap for today. We're going to go on a little 5-part journey. First, we'll talk about the art of listening. Then, we'll see how a life story is mapped out. After that, we'll walk through the famous mental status exam, learn how to decode the inner world of thoughts and perceptions, and finally, see how it all clicks together with the biopsychosocial puzzle.
First up, we have to start with the most important skill of all, the art of listening. And trust me, this is about so much more than just hearing words. It's about creating a space that feels safe, empathetic, and totally confidential. A space where a real story can finally come out.
You see, listening, in this context, is not a passive thing at all. It is an incredibly active process. The clinician isn't just sitting there soaking up information. They're guiding the conversation with open-ended questions. Think about the difference between asking, "Are you feeling sad?" versus, "How have you been feeling lately?" That simple shift is huge. It lets the person's own story emerge in their own words, and that's where the most valuable clues are always hiding. All of that careful listening then builds into our next big phase, mapping out a person's life story. This is where the real detective work begins, piecing together someone's past to make sense of their present.
And let me tell you, this investigation is thorough. It goes way beyond the immediate problem. We're talking about the entire history of the illness, past medical stuff, family dynamics, social history. They even look into the person's personality before the illness ever started. And why? Why go so broad? Because every single piece is a vital part of the puzzle. It helps reveal who the person is outside of their symptoms.
And one of the coolest tools for this is the life chart. This is way more than just a list of events. It's a visual timeline. On a chart like this, a clinician can literally see how a life event over here, like experiencing abuse, might be connected to the onset of symptoms, like delusions, way over here. It's all about spotting those patterns and connections you might otherwise totally miss.
Another really powerful tool is the family tree, or what's called a pedigree chart. This helps map out not just who's in the family, but also any history of psychiatric or medical issues across generations. You can spot potential genetic vulnerabilities, but it also gives you a deeper sense of the family system that person grew up in. It's kind of like zooming out to see the individual within their bigger family context.
Okay, so once all that history is gathered, the focus shifts from the past to the here and now. And this brings us to one of the most famous parts of the assessment, the mental status examination, or MSE. Think of it as a snapshot of a person's psychological functioning right in that moment, during the interview.
The MSE is basically a systematic check-in. It follows a really clear roadmap, starting with the stuff you can easily observe, like appearance and behavior. Then it methodically moves deeper into the more internal experiences, mood, thought, and perception. And it wraps up by looking at higher-level functions like cognition and insight.
The assessment really begins the moment the person walks through the door. Clinicians are observing everything: their grooming, their posture, how they move, eye contact, their general attitude. Are they cooperative or maybe guarded, apathetic? It's amazing how much information you can gather before a single structured question is even asked.
Okay, now for a really crucial distinction, mood versus affect. Here's the best way to think about it. Mood is the emotional climate. It's that underlying, sustained feeling a person reports like, "I've been feeling down for weeks." Affect, on the other hand, is the emotional weather. It's the moment-to-moment expression you actually see on their face. And sometimes, the weather doesn't match the climate. And that difference, that's a huge piece of clinical information.
From there, the exam moves into what is probably its most complex part: decoding a person's inner world of thoughts and perceptions. This is where the clinician really tries to understand someone's subjective experience of reality itself.
So a key concept here is the delusion. What is it?
Well, it's defined as a false and, this is the key part, unshakable belief. This is an idea that someone holds onto with absolute conviction, even when they're staring at clear evidence that proves it's not true. And that note about cultural background is vital, because what might seem delusional in one culture could be a perfectly normal shared belief in another. And delusions can show up in all sorts of flavors. You've got persecutory delusions, which is the persistent belief that you're being harmed or that people are plotting against you. Then on the flip side, you have grandiose delusions, with an inflated sense of self-worth or power. And then there are delusions of reference, where someone might believe that a news report or a song on the radio has a special, secret message meant just for them. And this right here is a perfect example of why it's so important to record things verbatim, word for word. A good clinician won't just jot down delusion of persecution. No, they'll write down the patient's exact words. My neighbor is trying to poison me. This keeps the unique, personal flavor of the experience and is just so much more descriptive.
So alongside looking at thoughts, clinicians evaluate perception, and that brings us to hallucinations. A hallucination is a sensory experience that feels 100% real but is happening without anything in the outside world causing it. The most common kind in psychiatric disorders is auditory, hearing voices that aren't there, but they can happen with any sense, from sight to touch to smell.
So we've gathered the history, we've done the mental status exam, now what? How does all of this come together? Well, this brings us to the final stage, assembling all these different pieces into one coherent, big-picture understanding of the person.
Now, a really critical piece of this final puzzle is something called insight, and it boils down to a pretty fundamental question. Does the patient actually realize that they have an illness and that they might need help? A person's level of insight, which can range from complete denial to a full understanding, has huge implications for whether or not they'll be willing to even try treatment.
So to organize all this data, clinicians often use what's called the biopsychosocial model. It's this incredibly powerful framework for looking at how biological factors like genetics, psychological factors like personality, and social factors like your support system all play off each other. Using this model helps explain what might have made a person vulnerable to begin with, what actually triggered the illness, and maybe what's keeping it going.
And this timeline just does a brilliant job of making that whole idea super clear. You've got these predisposing factors that create a vulnerability. Then a precipitating factor, some kind of trigger, causes the illness to start. And finally, you have perpetuating factors, which are things that might be getting in the way of recovery. It really shows how an illness is this dynamic process, not just a single isolated event.
Which brings us to our final question. The whole goal of this detailed, methodical, and deeply human process is to get to a complete story. Because, let's face it, a diagnosis is just a label. But a full understanding of a person, their biology, their psychology, their history, their struggles, and their strengths, that is the true foundation upon which any real, meaningful healing can actually begin.